One of the ideas that we've thrown around, big picture, we had to be able to have, we'd say we had a block grant in Georgia and we could do things over again. Take that $2,000 on average that the uninsured cost. I mean, some aren't very expensive, but one trip to the emergency room is about $1,000 on average, evidently. So rack up the cost very quickly. So $2,000 per person on average. Money we're already spending through tax dollars or some other way. Redirect that to these uninsured individuals. This is part of a lot of the Republican replacement plans for Obamacare, same concept. And so we're going to offer you a refundable tax credit or a voucher or whatever we'll say for $2,000 for you to buy comprehensive insurance. So if they're able to find a policy and they come to visit you or they have private insurance, that's great. Maybe we can't find it for that amount of money. So maybe we can find a direct primary care physician for $600, but you can't find an insurance product. So we would give the $600 to the individual to enter into that agreement so their primary care is covered, and the $1,400 would then go to the safety net hospital in their community to pay for their care. Or if they can't find a primary care physician, the whole $2,000 would go to the safety net providers. It would be a perfect feedback loop. So then our rural hospitals and all our hospitals would have a funding stream. We would have the ability to personalize care to that individual person so they could actually get access to primary care, which is the biggest problem. One of the big problems with Medicaid is it's hard to find a primary care physician. Hopefully that will keep them out of the emergency room. So that's the big picture idea. I want us to talk about that for a second before we open up for questions. What's your reaction to that? We'll start down with Josh.
I think obviously we don't have a free market system now. There's so much regulation and bureaucracy, and government pays for over 50% of care. So, but the free market is begging to take this on as a solution. I mean, more investment dollars from health startups or angel investors or VCs are going into healthcare. The ability is there to fix it. You just have to allow innovation to do that. So, innovation like direct primary care, direct specialty care, where you cut the waste out and turn it into margin. So the average doctor's office has 7 employees, or the average family physician. So a 3-physician practice should have 22 employees. We have 1.5. That 90% savings goes back to the patient, to their employer, to the insurance company, downstream, because we're more efficient. The fact that our medications are 95% cheaper, our labs are 95% cheaper, that goes back into the system to make everybody get more care more often for less money. So I think overall, we have to reward innovation, and we'll get a much more efficient system.
So when I look at the system, I see 2 different aspects to our system. One, Jimmy's problem, our inpatient system of providing health care in the hospital. And then I see our outpatient system where Josh works and I work a majority of my time. The outpatient system that we work in should not be expensive. That's why Josh can charge $50, $120 for a family of 4 to see him. Whereas if Josh were taking insurance, if he had the 7 employees that are required per physician, he would have to pay all of those employees more money to deal with the healthcare system, to do prior authorizations, pre-certifications, deal with claims denial processes, deal with ICD-9 coding, deal with pay for performance, deal with all of the unnecessary regulatory burden that doesn't provide health care. And when you add all of that unnecessary regulatory work and administrative work onto the physician's practice in the outpatient setting, you drive up costs. And you make it harder for people to be able to afford outpatient care. And so if we pause for a second and realize that outpatient care should not be something that's expensive and shouldn't be participating in the industry of healthcare, we'll find a way to actually make it a heck of a lot cheaper. And we do that, then that $600 that we can utilize to perhaps give to somebody who's uninsured in order to be able to then get access to somebody like Josh at 100% great care, a doctor that cares for them, a doctor that gets involved in his care, a doctor that actually has a motivation to make them healthy, to try to minimize their need to visit the hospital. Then we can actually really start leveraging health and wellness, and we can start doing it at a low cost. So we have to start realizing we have to separate these 2 things, and one system requires insurance, one system requires a lot of costs, the other system shouldn't. But if we take this outpatient system and move it into the inpatient system, we're going to take outpatient care and actually make it exorbitantly expensive that nobody can access. We separate and do what you mentioned there, at least in maybe the uninsured, we can give them access to health care.
When we think about the Accountable Care Act, it had three aims: lower cost, improve access, and increase the quality. It had tremendous unintended consequences. So one thing it aimed to do was provide health insurance for every citizen through mandates or expansion of Medicaid, and at the same time it would in effect lower the reimbursement across the board, because we would no longer have to enter this shell game of shifting costs from the uninsured to the insured. Well, we got the second part of it. Reimbursement is declining, but we didn't insure our patients. Now, some of you have more expertise in this area than I do, but I understand there's about $3 billion that would have come to Georgia had we expanded Medicaid. And there are a lot of reasons we haven't done it. When we look at cost, and when I say cost this time, I mean actual real cost, not price. In Georgia in the year 2012, the uncompensated cost of hospitals was $1.6 billion. Our share in Sandersville was $4.5 million. So I don't know how much the physician piece was in other parts of the provider space. But if hospitals is 1.6 and there's $3 billion that Georgia did not receive because we chose not to expand Medicaid, then there's an opportunity there for us to figure out how to take a smaller portion of that $3 billion and solve this problem. Because if we start compensating providers for the care of each patient, then the cost will come down. We will no longer have to figure out, is it inpatient or outpatient? Do we shift the cost from this one to that one because they've got better insurance? We can find the most effective points along the distribution system, and we'll have transparency.
But what we're talking about is not creating more Medicaid recipients.
No.
We don't want to add to all the rules and regulations, and we're not adding to this entitlement program. It is premium assistance to help these individuals buy insurance. And there's going to be personal responsibility. They'd be expected to pay some portion of the premium up to a limit based on their income. Friends and family, charity, the community, religious institutions could also help them. Say I'm the ne'er-do-well nephew who had been in and out of drug abuse, and I want you to give me some money as my uncle. Not going to give me money, but I say, hey, could you contribute to a third party and that would allow me to buy health insurance so I could get treatment? You might be willing to do that. So I believe that it's a part of the solution. Can we do that? Is that a conservative idea? And then we're going to let other people ask some questions. Brian?
Well, the thing I'll say about that, Kelly, is, and we get the semantics mixed sometimes, is we keep on talking about bringing insurance to people rather than access to health care, and we've heard that a lot. This is talking about bringing access to health care. Now you have access to a wonderful physician that if you were uninsured or if you were even a Medicaid recipient, we do not see a high uptake of physicians taking Medicaid at the state. So while you have a card in your pocket, it really doesn't do you a whole lot of good if nobody takes it. You're a bit of the pry in the medical community when hospitals lose 15% on Medicaid, physician groups, we get paid 58% of the healthcare dollar to take care of somebody with Medicaid. We lose money when we see Medicaid. And so you've taken somebody who would either be through Medicaid expansion, not really getting access to health care, or is uninsured who doesn't have access to health care, and now you're giving them access to health care, not just health insurance. And that's what this allows to come forward. And I think that is a great step in healthcare. And then if we can do this in a place where it does create some competition in the market to allow people like Josh to reach out and try to find a way to bring them medications, to get imaging in the outpatient setting at a cheaper rate, then we can really start trying to drive the price of healthcare down.
Well, the opportunity I see too is Georgia is a leader in telemedicine. What you're doing in Sandersville is incredible. We are a leader in health IT. We have incredible healthcare assets, yet we have, in some rural areas, worse than third world healthcare outcomes. We can be a leader in turning this around here in Georgia. We have the ability, but we need to have a system that allows for innovation. There are a lot of small companies out there that have these wonderful ideas, but they don't fit in the box of Medicaid, that if we allowed for innovation, and allow money to flow to those that can solve these problems, like Josh is in primary care, I think we can solve the problem.